of the thorax. And obviously, bones of the thorax will protect the lungs and all the organs that are inside the thorax. So that's number one function of the muscle of the bones. Protects the vital organs. And then to write some notes on the sternum, vertebrae, and ribs. You have your notes in front of you, but I'll leave the picture showing. So for the sternum, just to describe the sternum, it's costal cartilage and ribs are attached to the sternum. Costal cartilage is the type of cartilage that's attached. So costal cartilage and ribs are attached to the sternum. And when you're looking at the picture, you see the sternum in the center, and then you see this white material, and that's the cartilage. And then attached to that are the ribs. A lot of notes to write. The next one describes the parts of the sternum. The manubrium. Do you know how to spell manubrium? The body. And the xiphoid process. All right, so manubrium, the body, and the xiphoid process. Where the manubrium meets the body of the sternum, it sticks out, and you can feel it when you palpate your chest. You can feel a bony structure sticking out, and that's where the manubrium and the body meet. And it serves as a great anatomical landmark. That's where the second rib attaches. So when you're doing a 12-lead EKG and you have to figure out where to put the electrodes have to go on a certain rib. You start with the fourth rib, which there's no real landmark for the fourth rib, but there is for the second. You feel that bony process, and you say, aha, that's the second rib next to it. And then you palpate a space, and then you palpate a rib. Okay, that's the third rib. Palpate a space, and then the rib after that is the fourth rib. And that's where you would put your first electrode. So that's how you use the angle of Lewis. The other thing with the angle of Lewis is if you could see inside the thorax, you would see that the trachea divides into the right and left main stem bronchi at that point. I think your test question that I gave you in the introductory class, it asked for hand positioning during CPR. Do you place your hand on the manubrium, the body, or the xiphoid process? Do you remember that question?
Yeah. It was the body.
It was the body, right. All right, on your notes, it lists vertebrae. And on the back of the thorax are the vertebrae. And the vertebrae that have ribs attached are called thoracic vertebrae. Do you remember the parts of the spinal cord? Like up in the neck, you have your cervical vertebrae. Mm-hmm. Part of the thorax is your thoracic vertebrae. Below that is your, what is it? Lumbar and sacral vertebrae.
What do you call them, the vertebrae? The ribs at the vertebrae?
Thoracic.
Yeah.
All right. For ribs, you have to write down the number of ribs that we have. Do males and females have the same number?
No.
You're reading the Bible too much.
Okay. I mean, yes.
Yes, there are.
Yeah.
12 pair of ribs.
Multiple.
Some of the ribs directly attach to the costal cartilage, and others attach to the cartilage, which attaches to the sternum. How important is that? Not real important. when you're looking at the rib cage, we know that inside we have the mediastinum with the heart and all the major vessels. We know we have the lungs in there. There's more organs that these ribs protect other than just the heart and the lungs. And in the back are the kidneys by the lower ribs. So they're protecting the liver, the kidneys, the spleen is in there somewhere. So the ribs protect more than just the heart and the lungs. And the reason that I'm telling you that is you're going to learn how to do chest physiotherapy. And that entails clapping on the chest to loosen secretions. You typically position a patient with their head down, laying on their side. Sometimes you'll lay them even on their belly, or prone, I should say. And then you're going to clap on their lungs. And the clapping causes a vibration in the airways, and it makes the mucus move towards the upper airway so they can cough it out. So when you're clapping, you might think, okay, well, the ribs end here. Let me just clap down to the end of the ribs. But you're not. At that point, you're clapping over the kidneys, and you could damage the kidneys. So don't think when you're doing your chest physiotherapy, you're supposed to go all the way down to where the ribs end. So that's an application of looking at this anatomy. What else does it say? Movement of the rib cage is to increase the size of the thorax during inspiration. So the ribs come up and out during inspiration, and that makes the thorax larger. So the ribs move up and out during inspiration. To make the thorax larger. This picture shows the internal organs underneath the bones or underneath the ribs. Can you see a dotted line going through this?
Yes.
It's supposed to be the diaphragm, yes. And it's up kind of high. It's showing it between the fourth and fifth ribs. Typically, you see the diaphragm at the seventh to eighth rib. So, rib 7, rib 8 is usually where the diaphragm is, and that's where the lungs would end. 7th to 8th rib. The movement of the ribs is more like the movement of a handle on a bucket. So it's called the bucket handle movement. And again, the ribs move up and out to increase the size of the thorax. Since you wrote that already, I don't think you need to repeat it on this slide. All right, so that's it for the bones of the thorax. Now we go into muscles. The title of this is Primary Muscles of Ventilation, and by primary it means the main muscles that do most of the work, even though there are other muscles that are active during inspiration. So the first one listed is the diaphragm. Again, it's active during quiet breathing and with exercise. The diaphragm is a flat muscle. It's not even a ½ inch thick, it's very flat. And the shape of the diaphragm is dome-shaped, D-O-M-E, dome-shaped. And then write down that the right side sits higher than the left. The right side sits higher than the left. Do you have any idea why the right side of the diaphragm would be up higher?
Liver?
Yes, very good. The liver, it exists underneath the diaphragm, so that kind of pushes up the diaphragm a little bit. So the right side will always be higher. I'll show you the picture in a minute. For intercostal muscles, there are 2 sets of muscle fibers between each pair of ribs. There are 2 sets of muscle fibers between each pair of ribs. Okay, and then the muscle fibers, there's the external intercostals and the internal intercostals. Question?
In the book, it calls them differently. I think it calls them parasternal and interosseous. Do we just have to write just external and internal?
Yes, so external and internal.
That's what I'm sure.
If you ever answer a test question and you quote something from the textbook, that's okay. If I happen to mark it wrong, just show me the textbook and I correct it.
Okay. No, but
So-
it's much more simpler, the internal and external anyways. But yeah, just want to make sure.
Yeah, I'm glad you pointed that out. Oh, we don't have sound? I don't think we can. Oh, there, I hear it.
It's just low.
It ends its shape from its attachments and from the organs that surround it, especially the heart, lungs, and liver. The diaphragm attaches at the costals along the lower rib cage, high in the front of the sternum, and deeply in the back along the spine. The diaphragm also attaches to the Sept via a central tendon, making the diaphragm one of the unique muscles of the body. The diaphragm uses its central tendon and its attachments as leverage to flatten during inhalation. The expansion of the ribs comes from the resistance of the internal organs to downward movement. As the internal organs are slow to move, the ribs expand to make room for the lungs. While the diaphragm attaches at the bottom of the ribs, its range of motion never reaches that low in the body. As seen from below, we get a sense of the full range of motion of the diaphragm as it will glide over the aorta, the vena cava, the esophagus, and the internal organs. For more information, visit www.
So that shows the movement of the diaphragm, which is pretty neat to see. There's my escape route here. There's some more pictures of the muscles of ventilation. So when you're looking at the diaphragm, it's good to have seen the video of it because you can appreciate how flat the diaphragm really is. Here it looks like it's really thick, like it's big and fat like the liver, but it's not. It's a very thin muscle. In order for it to contract, it's got to push down the abdominal muscles in order to flatten. So the abdominal muscles are going to respond by wanting to go back up into their position, and that kind of helps during exhalation to push the diaphragm back to its resting position. So it squishes the abdominal organs during inspiration, and then when the diaphragm relaxes, the abdominal organs kind of push it back into its resting space. And then we see the internal intercostals and the external intercostals. Oh, okay. The abdominal organs exert pressure against the diaphragm. When the diaphragm contracts, it compresses the abdominal organs. When the diaphragm relaxes, the abdominal organs decompress and move back up. This aids a passive exhalation. So I don't know if the picture helps or if the words help, but that's the point that I was trying to make. So when you're looking at the x-ray, can you see where the diaphragm is on the x-ray? You see the dome shape of the diaphragm? And it tells you why you see like a white line, and then grayish, and then white again. And it tells you that the stomach is underneath the diaphragm, and there's an air bubble in the stomach, and that's what you're seeing. Which part of the diaphragm is higher? The right. Is it obvious in the picture that this is a little bit higher than the left? Just a little bit? The heart rests on the diaphragm. Was there any other point to that? I think that was it. Just that the heart rests on the diaphragm.
It says that the heart pushes the left side lower a bit.
Yes. Yeah. That was the other point. A lot of people end up going to the emergency department because they're having an upset stomach. And one of the things that they'll do is try to rule out any problems with the heart at that point. Because the heart and the stomach are so close to each other, sometimes the pain seems to be related to the stomach, but it's not. It's actually ischemic heart muscle causing gastric upset. All right, so the accessory muscles of ventilation are used during exercise with heavy breathing, or with lung disease, such as obstructive lung disease. Did you get all of that?
Yes.
All right, so normally the diaphragm and the intercostals are active during quiet breathing, but then when you start exercising and you need to breathe fast, there's other muscles that come into play to help get the air in and out of the lungs, instead of just the diaphragm and the intercostals working. So that's this list of muscles. The first bullet is called scalene muscles. These are the neck muscles, and they attach to ribs, and they raise the first and second rib. And then they're somewhat active during quiet or normal breathing. So let's look for scalene muscles. Whoops. So we're looking for muscles in the neck that lift the first and second rib. Pretty obvious, right? See the first and second rib, and then you've got these muscles that come from the neck and attach to the rib. So their purpose is to lift the rib cage. Why do you think the body needs to lift the rib cage?
So will it expand?
Right, very good. So it wants to expand the volume of the rib cage, and that's the purpose of it. The next one is the Sternomastoid muscles. And they're called the strap muscles of the neck. They attach to the sternum and to the mastoid bones. They raise the rib cage. All right, look for the sternomastoids. They used to be called the sternocleidomastoids. Now they're just called sternomastoid.
They changed it?
So they attach to the sternum, and they attach to the mastoid bone on the jaw. So sternomastoid muscles. Pectoralis major lifts the rib cage. So the pectoralis major attaches all the way down the sternum and then inserts into the arm. And this can also lift the rib cage. All right, so that's it for accessory muscles, ventilation. Abdominal muscles help during exhalation. Let's see, so we're missing something here. For the scalene muscles, the sternomastoid muscles, the pectoralis major, these are all helping during inspiration. So put a note on your paper somewhere. So the first three are helping with inspiration. And then the pectoralis, Yvonne. The abdominal muscles function during exhalation to force air out. So it says it, I don't know if you need to add it to your notes. So you've got muscles that help with inspiration and muscles that help with exhalation. And then patients with chronic obstructive lung disease use the muscles listed above because their diaphragm is always in a flattened position. And so that's what I need to explain to you. Let's look at this picture while I'm explaining it. All right, so when you breathe in, the diaphragm has pushed down and air is able to come into the lungs. And then on exhalation, the diaphragm pushes up and helps to push the air back out of the lungs again. Well, imagine somebody who has really obstructed airways. They've been smoking for a number of years, and all the supporting structures in their airways are no longer there. They've lost their elasticity, and they're not supporting the airways. Well, our airways tend to narrow when we exhale normally. So imagine not having any structure to hold the airways open. So the airways almost close during exhalation. So patients that have this obstructive lung disease, they can breathe in just great, but then they try to exhale and not all the air comes out. Some air stays trapped. Well, trapped air, as it increases and there's more and more volume of trapped air that can't exit the lungs, it pushes down on the diaphragm and causes the diaphragm to stay flat all the time. So when it's time to take the next breath, the diaphragm's supposed to contract and then air can come in. But if the diaphragm is already contracted and already flat, how is air going to come into the lungs? So that's when the body says, okay, diaphragm's not able to do its job, so the accessory muscles can go to work and help to pull the air into the lungs. So you'll see patients that have obstructive lung disease, they tend to like to sit forward and lean on their arms so that they're using the strap muscles in their neck, the sternomastoid muscles, to lift their rib cage to get air into their lungs. So the scalenes, the sternomastoids, really have to work hard in those people to try to get air into the lungs. So that's the explanation. I'll give you a minute to figure out how to word it so that you can write that on your paper. What do you have to mention? You have to mention obstructed airways cause air to be trapped. So obstructed airways cause air to be trapped in the lungs. How about this prevents the diaphragm from recoiling or returning to its dome-shaped position? Or whatever you can think of. So it prevents the diaphragm from returning to its dome-shaped position, or maybe you can think of other words to describe it.
Returning to natural dome shape.
Yes, returning to its natural dome shape. All right, and then what would be the next sentence? Now the next breath becomes very difficult, or inhalation becomes difficult, or?
When inhalation becomes difficult, the scalene muscle pick up this,
Work of breathing.
the accessory muscles pick up the slack.
Okay, so now that the diaphragm is flat, the accessory muscles have to work to pull air into the lungs.
And for exhalation, the abdominal muscles would have to be involved also to push the air out,
Yes,
because the diaphragm is still flat.
yes, very good point. Is that on the slide? Because if it's not, you have to add it. Okay, so that's also a note that you have to add. On exhalation, exhalation is usually passive. No muscles have to work for air to exit the lungs. So exhalation is a passive movement. No muscles are needed for exhalation to take place. However, with trapped air in the lungs, so with trapped air in the lungs, with exercise, now exhalation becomes active. And the abdominal muscles will push the air out of the lungs. So the abdominal muscles will push the air out of the lungs. So abdominal muscles, it labels them the rectus abdominis, external obliques, the transverse abdominis. There's no need to memorize the names of the abdominal muscles. All you need to refer to them as abdominal muscles, and that's good enough. What causes air to enter the lungs when we breathe in? Negative pressure. Very good. So this describes inhalation. It says that a subatmospheric pressure is generated when the thorax increases in size. The increase in size occurs when the diaphragm contracts downward and the ribs move outward. And now air moves from higher pressure, which would be outside the atmosphere, to lower pressure, which would be in the lungs. I think you need to add some notes to that. This is a difficult concept, and a lot of people struggle trying to understand what causes air to enter the lungs. A lot of people believe that the air goes in, and when the air goes in, it pushes the diaphragm down, and that's completely not true. So air does not push the diaphragm down. It might seem that way because when you're breathing in, you can kind of feel the air going in, and it feels like it's the air itself pushing everything down, but that's not how it happens. So what happens is first a negative pressure has to be generated in the lungs, and that's what's pulling the air into the lungs. So what causes the negative pressure It's the diaphragm contracting down and the ribs coming out. Because when that happens, it increases volume, and it's almost like a vacuum where it's sucking air into the lungs. So that increase in volume is actually the way that the lungs create that negative pressure. So if you want to add something to your notes that describe it, rather than just what's on the bullets, to help you understand that. Do you have any questions, or how can we clarify that?
In my first anatomy class, she described it as just basically like, I forget what it's called, but it's like a suction needle, I guess you could say it. And when you pull back, it creates that negative pressure, so it sucks in all the liquid that you're trying to get inside the needle.
Yeah, that's a good analogy.
So it's not the liquid pushing it in, it's the suction.
That pulls it in. Yeah, that's a great analogy.
So basically, the diaphragm flattening and the ribs coming out is pulling the air in?
Yes. And the one sentence that you could add to that is that when the diaphragm contracts and the ribs go out, it creates a negative pressure in the lungs. And then with exhalation, it says that it's completely passive, so no muscles have to move for exhalation to occur. Exhalation occurs when the diaphragm relaxes and returns to its resting position, and the intercostal muscles relax. So everything relaxes, and when the diaphragm goes back to its resting position, that's pushing the air out, so no muscles have to work. But you already wrote down what happens when you have air that's trapped in the lungs from obstructed airways, or even with heavy breathing. Now exhalation becomes active. What is the significance of obesity on diaphragmatic movement? So you have a lot of adipose tissue sitting on the abdomen. Do you think that the diaphragm can descend the same amount when it has to push against all that adipose tissue? No. So if the diaphragm doesn't move very much because of all the pressure from the weight, how would that affect the volume of air going into the lungs? Do you think the volume of air would be the same? Do you think it would be more, or do you think it would be less? Less. Very good. So less movement of the diaphragm, less air comes into the lungs. So the significance of obesity would be that the weight prevents the diaphragm from moving its normal amount.
I guess you could say it's almost like, you know, suitcases now that they have that expand. If you put more stuff in, you can make it a little
You can
bigger.
expand the suitcase?
You can expand the suitcase, you can make it a little bigger.
Okay.
If you think of that, the diaphragm is that, if you have it already full, you can't expand it anymore.
Yeah, that's a good analogy. All right, so everybody wrote something down to answer the question? Got it? Okay. All right, so innervation of the lungs, and the word innervation means nerves feeding the tissue. And the phrenic nerve innervates the diaphragm. I want to show you a picture of where it comes from. This is a good picture. So you see where it says C1, 2, 3, 4, 5, 6, 7. Those are all the cervical vertebrae. And the phrenic nerve branches off of the 3rd, 4th, and 5th cervical vertebrae and travels down the mediastinum to the diaphragm. So your notes say it branches off of the cervical vertebrae, 3, 4, and 5. So there's a mnemonic that goes along with that to help you remember it. It's 3, 4, and 5 keep the diaphragm alive. So whatever it takes to help you remember these things. All right, so if you're working in the trauma and you get a report on a patient that has a fractured cervical spine and it fractured at level 3, that tells you that below that fracture, there isn't going to be communication of the nerves. So now the diaphragm has been affected from that cervical fracture. So if it's 3, 4, and 5 and the fracture happens at 3 and above, now it's going to affect diaphragmatic movement and the person's not going to be able to use their diaphragm to breathe. Sometimes they end up on a ventilator the rest of their life. Sometimes they're able to use accessory muscles to compensate for not having a diaphragm that's working. So that's the application of that. The other thing is with the phrenic nerve traveling through the mediastinum, sometimes with open heart surgery, they have to stop the heart to bypass vessels or to replace a valve. And the way to stop the heart is with this solution. It's cardioplegia solution. It's real high in potassium. And that stops the heart from beating. And then it also, it's really cold. And the phrenic nerve sometimes gets damaged from that cardioplegia solution. And then after surgery, everything's fine. And then you'll notice that the patient can't breathe well enough to come off the ventilator. But they were fine a few hours ago before they went to surgery, and now they're not breathing okay. So one of the things to be suspected is that the phrenic nerve got damaged during surgery from that solution freezing it. So a few days later, it'll start working again. Sometimes it never starts working. So just one of the complications of having abdominal surgery, cardiac surgery.
So the phrenic nerve is like a battery pack to the muscles that move the diaphragm.
Yes. Yeah. It's a battery pack to the diaphragm. All right, and then to tell you about the vascular supply. The pulmonary circulation refers to blood that leaves the right ventricle and travels to the lungs through the pulmonary vessels. We have a lecture coming up on pulmonary circulation. So blood flowing from the right heart to the lungs to pick up oxygen and then coming back to the left heart. There's other blood that flows to the lungs, and that's the second bullet, and it's called bronchial circulation. These blood vessels supply lung tissue with oxygen. So it's the part of the lungs that's not getting any blood supply from the pulmonary circulation. So it tells you, however, much of the lung parenchyma, and parenchyma is like tissue, the connective tissue, elastic tissue, is oxygenated by direct contact with inspired gas. So we have a picture. What are we looking at here? We're looking at conducting airways. They branch and branch and branch until they get into the alveolar ducts and alveoli. We've got a weird picture here. It says alveolar air space and it points here. All right, so I guess this is representing the part of the lung that gets perfused by pulmonary circulation, the blood that left the right heart traveled to the lungs. But then there's also structures in the lung that don't receive enough oxygen that way, so they need their own blood supply. And that's the bronchial circulation. So it's showing it here as a thin artery that's feeding the tissues of the conducting airways. So bronchial circulation. All right, and then lymphatic vessels they clear fluid from the interstitial spaces, so we don't want to get extra fluid building up the interstitial space. So how do we get rid of fluid in that area? Well, the lymphatic system will drain fluid from the interstitial space. And lymphatic fluid is also part of the immune system. That ends our show.